Good afternoon, everyone. My name is Dr. Tamer Aboushwareb. I am the Chief Medical Officer at Pacific Edge Diagnostics, and I'm talking to you today about our product, the Cxbladder Triage Plus, which is the second generation of our Cxbladder genomic urine test for hematuria evaluation. As you may already know, very few people with asymptomatic microscopic hematuria actually have bladder cancer. However, guidelines all over the world require the majority of those patients to undergo invasive evaluations. This is usually considered a over-diagnosis or over-procedures for these patients, yet it is still recommended by most guidelines. In the United States, approximately up to 20% of Medicare beneficiaries and maybe 25% of the general population will present with hematuria annually. 80 to 90% of these patients that are diagnosed with UC will present with painless hematuria, and only 20 to 30% of those patients will present with irritative symptoms. However, cancer is only identified in 3 to 5% of those patients, and possibly up to 23% of patients with gross hematuria. The most common probability is the urothelial cancer in the bladder. However, there are other common causes for hematuria, including renal cell cancer, stones, infection, BPH, medical renal disease, and probably the most common is just idiopathic microscopic hematuria. The EAU guidelines still, till today, recommend cystoscopy and CT scan for all microscopic hematuria patients. However, they also, even though not recommend urinary biomarkers or cytology, they do mention that there are, in the statement below, that there are some tests, including Cxbladder, ADXbladder, and Cxbladder, that, although not tested in RCTs, have such high sensitivities and negative predictive values that they may approach the sensitivity of cystoscopy, and that those 4 tests might be used in initial diagnostic workup to avoid implement cystoscopy. Those guidelines were written in 2024, and since then, we have published a couple of different papers that show the utility of our test in the microscopic hematuria population, which led to the update in the AUA SUFU guidelines for evaluation of microscopic hematuria. If you remember, in the 2020 guidelines for AUA, there was a specific statement mentioning or saying not to use urinary biomarkers for evaluation of hematuria. This has drastically changed this year. In the new update, and due to the data that was recently published from us and from other biomarker companies as well, they have now changed their recommendations, where even though they still classify the patients into 3 different categories, the low negligible risk, which in this update, the AUA recommends no cystoscopy, but rather a repeat urine analysis within 6 months after initial presentation. The intermediate risk, now the physician or the AUA recommends cystoscopy and renal ultrasound as their initial recommendation. However, they also say that clinicians may offer urine cytology or validated urine-based tumor markers to the appropriately counseled patients to facilitate the decision regarding the utility of cystoscopy. Renal and bladder ultrasound should still be performed. In the intermediate risk population, which is probably the largest population you will see in your offices, the AUA has now drastically changed their tone and have said that if you appropriately counsel your patient, you can use biomarkers to determine if they need cystoscopy or not. Of course, in high-risk patients, they still recommend cystoscopy and CT scan, although we believe that based on the data that is coming out from us and others, that will change in the future. This is the list of biomarkers that are listed at on the AOA website that they now have recommendation for. As you can tell, there's multiple biomarkers that have been added, including obviously NMP22, Assure MDX, Cxbladder Triage, and Cxbladder Resolve, Early Tech BCD, urine cytology, Eurovision, and Cxbladder. Having said all of that, if you look on the right-hand side where the AOA strength of evidence, you can see clearly that the Cxbladder Triage, which is the precursor of the test that we are talking about today, is the only one that received a level A strength of evidence. And that is based on a randomized controlled trial that has been run and showed the effectiveness of our test in this population. This, right now, the AUA risk stratification recommends, like I said, for the low risk not to do cystoscopy. However, the unfortunate thing is only 5%, maybe 10% at most, of patients that you see in your offices will actually meet the criteria of low risk as per definition. And thus, you're only removing 5, maybe 10 patients at most if you use the AOA risk stratification. What are the advantages of urine-based genomic testing? Generally speaking, the genomic testing samples the entire urothelium, including the upper tract. So it is not localized to the bladder, which means if a test is positive and your cystoscopy is negative, it is not out of the question that there is something in the upper tract, which is why we always recommend at least an ultrasound, possibly a CT, if there is a higher probability of that for your patient. It is also not operator dependent. As you all know, we can look at the bladder and somebody will see a small tumor, somebody will miss it. In genomic testing, this is not the case. Genomics can detect malignant changes that may not be evident by histology or cytology, which is something that is very important, and we truly believe it, is that a preclinical tumor can be detected using genomic testing while it may still not be visible in the bladder or upper tract. That doesn't necessarily mean that there is a tumor that you have to remove right now because obviously you can't see it, but it just, a positive test should indicate that a patient should be followed and not completely ignored in the future. Obviously, one of the benefits of genomic testing is that you can adjust the algorithm to optimize the diagnostic parameters for a given clinical scenario. So in our own testing, we have developed 3 different tests based on the same 5 biomarkers by optimizing the algorithm based on the different populations of patients that we need. And then for our testing, one of the things that we do offer in our company is the possibility of in-home sampling, which can obviously change the pre-visit cancer risk and lead to more optimum scheduling for your offices if you choose to use these options. This is the study that I've mentioned earlier. It's a STRATA study, which was a randomized controlled trial comparing Cxbladder Triage to cystoscopy in patients with microscopic hematuria. And the hypothesis of the study was in a prospective randomized trial, the knowledge of the Cxbladder Triage would reduce the number of cystoscopies done in lower risk hematuria patients. As you can see, in this particular study, which was started in 2019, the patients were categorized as lower risk or not lower risk. This definition was used because the study protocol was written before the AUA 2020 guidelines, and the recommendation of our experts at the time was to use this definition of low risk as having RBCs between 3 and 29 and less than 10 pack per year smoking. Those were the only criteria used to determine lower risk. And anybody above that was not lower risk or basically a high risk. And because of that, the reality is there was a lot of lower risk patients that would be considered today as intermediate or high risk by the AUA definition today. As you can see on the left, the patients were enrolled. They were randomized to either testing arm or control arm, and the test arm were given the results of the test, and if it was negative, the recommendation was to defer cystoscopy, and if it was positive, recommendation was to do cystoscopy, and then obviously if it was the standard of care, the patients were treated according to the standard of care for the physician. This study was run in 11 different sites, and these are the results of the study. If you can focus on the middle two columns, you can see that in the test arm, there was only 27% of patients received cystoscopies versus a 66.7% of patients in the control arm or the standard of care arm received cystoscopy, which resulted in a 59% relative reduction in cystoscopy, which is a significant number. But if you dig deeper on the right, you can see that in the triage test negative side, only less than 20% of these patients received cystoscopy versus 80% of the test positive did. And if you used all the accuracy measures, you can see that the sensitivity of the test was 90% with a negative predictive value of 99%. And there was only one patient that subsequently was test positive about 13 months later, and they did have a tumor. But other than that, no tumors were found in the lower risk population at all that were negative with the test. Now we'll talk about the Cxbladder Triage Plus, which again, as I mentioned earlier, is the next generation of the Cxbladder Triage that we developed by adding DNA markers to our original RNA markers. This is the description of the actual markers that were included in the new Cxbladder Triage Plus test. As you can see on the left, these are the original 5 RNA biomarkers that are currently in the triage test and the detect test. And then on the right, you will see the addition of two genes with 6 different single nucleotide polymorphisms. And the 2 genes were the FGFR3, which is very well known to be associated with bladder cancer, and TERT, which is a prospective or a predictive marker of bladder cancers. Those 2 genes and the 6 single nucleotide polymorphisms were added to the original 5 RNA markers. As you can see, the first publication for this, the development of this test was published in 2023, which was the addition of these new markers. And basically, the results were as follows. At that time, we had very briefly did the algorithm, and the data was published under Cxbladder D Plus or Detect Plus, which was then modified, and I will show you the modification. But the original algorithm showed a sensitivity of 97% overall, a specificity of 90%. This was a single cut point, a negative predictive value of 99.7%, a positive predictive value of 44%, and a rule out rate of 83%. As you can see, this was a significant improvement on the current or the available triage test that we have. This is a direct comparison on the same data set between the current triage and the Detect Plus, which as I said, I will show you how it was developed into the Triage Plus. But it showed a significant improvement in sensitivity, specificity, negative predictive value, and positive predictive value of that test, including the rule out rate. And that's why we were determined to improve our testing and worked on improving the second generation as well. The conclusion of that initial data set was that second generation Cxbladder test have been developed where the algorithm incorporates the single nucleotide polypeptides in addition to RNA expression, which was at the time Detect Plus. The Cxbladder Detect Plus had significantly improved sensitivity and specificity compared to the Cxbladder Detect and Triage, and 83% of patients were Cxbladder Detect Plus negative and could therefore have been spared cystoscopy. And this was the original kind of data set. We have since taken this data set and added to it more and developed the most recent test, which is now called Triage Plus. This Triage Plus still uses the same 5 RNA markers plus the 6 SNPs. However, we have refined the algorithm dramatically by including another 400 patients on top of the original about 830. And we now have 2 cut points. The goal of this new testing or algorithm was to not only improve on the negative predictive value, but we wanted to also provide you and the patients with a higher cut point that can actually improve and be significant in detecting the patients that have the highest risk of having urothelial cancer. And as you can see from this data, if you're using the lower cut point, which is the 0.15, the sensitivity of the test is 93.5. The negative predictive value is 99.4 with a rule out rate of approaching 85%. When you use the higher cut point, you now have only, the sensitivity drops, which is not the point here, but the specificity, as you can see, increases to 98%, and the positive predictive value approaches 75%. And you only have approximately 6% of patients in that higher risk population. This is where we believe that the test truly shines, where you can exclude 85% of the patients under the lower cut point with a 99.4% negative predictive value, safety, while really focus on a 6% of the population that truly have the highest possible risk for harboring urothelial cancer in that upper tranche above the 0.54. In the middle, these patients still need to be evaluated, so you still need to do it, but they may be deprioritized, where you work the higher risk patients first and then the medium risk patients. The next study that was published was just recently published about a month ago, and this was the Savage et al. This was a study that has been ongoing for approximately 5 years. It was done in 9 sites in the VA in the United States, the Veterans Affairs, 10 sites, I apologize. It included 702 patients that were screened. As you can see, the exclusion criteria, 615 patients for all Cxbladder test clinical validation were available, and 28 of those patients did not have a Triage Plus result for multiple reasons. So we ended up with 587 patients that were in the population that was analyzable. And as you can see, the methods was a multi-site recruitment of patients with hematuria. We included all hematuria in this study, so both microscopic and gross hematuria. Patients underwent all routine clinical investigations and provided urine samples. The clinicians and patients were blinded to the Cxbladder results, and then the performance of the Cxbladder test result was evaluated compared to cystoscopy or ureteroscopy and pathology as the gold standard. This study represents the external clinical validation of the Triage Plus algorithm for risk stratification using the biomarkers I already mentioned. These are the results of the study. And as you can see, under the 0.15 cut point, the sensitivity of the test is maintained at 94%. The specificity is 77% at that cut point. The positive predictive value is low, which is not where it is, but the negative predictive value, as previously mentioned was 99.3% with a rule-out rate of 71%. So the rule-out rate dropped a little bit in this population. This was a much higher risk population than previous studies, but it still maintained the negative predictive value and a very, very high sensitivity. On the upper end, the 0.54 cut point, your specificity is 95%, and the positive predictive value, again, dropped a little bit, but still over 50% with a rule-out rate, obviously, of 90%, but that's not relevant for that cut point. In comparison, the triage test had a sensitivity of 93%, which is very, very good. It still is very high. A negative predictive value of 98.5%, which is perfect. However, the triage test only had a specificity of 38% and a rule-out rate of 35%. So the Triage Plus, even though has very high sensitivity and very high negative predictive value, ruled out approximately half of the patients and could not tell you which patients to really focus on. So this is where the addition of these DNA biomarkers have really dramatically improved the upper end of the test, and we are truly very proud of the accomplishment that we have here. We have, because of the performance of this test, we have committed a lot of resources and a lot of money to producing the best possible clinical validation data and clinical utility data for this test. So I showed you the results of the original analytical validation data, which was published earlier in 2025. We have also just published I showed you the drive data that was published in September of 2025. And we have two other ongoing studies that will be used for clinical validation. The Aussie trial, which is run in Australia, which is already finished right now. This is a little old slide, says 50% completed, but it is completely accrued and will be published within the next few weeks. And that study recruited over 750 patients. And then we have the microdrive study, which is currently again running in the US VA system and is slated to recruit 1,000 patients and will be hopefully fully recruited and will be published by the end of 2026. We also have started the largest prospectively randomized clinical trial ever to be conducted in this area, which is the CREDIBLE study. It is currently running in 15 sites across the United States, and will recruit up to 1,000 patients that will be randomized to test arm versus control arm. And those patients that on the test arm will all receive Triage Plus and testing, and will be, dealt with or managed according to the results, versus the control arm will be managed accordingly. And the primary objective of the study is to show the reduction in cystoscopies without reduction in number of tumors detected. This study is slated to completely enroll by the end of 26. There is a 6-month follow-up for the study, and then hopefully will be published by the end of 2027. This is the Cxbladder Triage Plus, our suggested clinical pathway. And as you can see here, we tried to follow the AUA SUFU guidelines from 2025. If a patient is referred to you with microscopic hematuria and you use a Triage Plus to risk stratify, patients that are under the lower cut point of 0.15 should be deferred from their evaluation and repeat the UA within 6 months. Patients that fall in the intermediate risk, which is between 0.15 to less than 0.54, those should be have a suspicion of UC, not a very high suspicion, but certainly should be evaluated. They need a renal ultrasound and cystoscopy. And then the last category is obviously the Cxbladder Triage Plus score of above 0.54, which we would consider high suspicion of UC. those patients should obviously be prioritized for cystoscopy and a CT urogram. This is obviously our clinical pathway suggestion, but different physicians will manage their patients according to their clinical status and how they judge their patient. This is, again, the suggested clinical pathway in a slightly different way, where, obviously if the patient presents with hematuria, if there is UTI or transient benign cause suspected, then there really should be treatment for that benign cause before you move the patient towards any evaluation for hematuria. And then within 6 weeks, if there is no improvement and the hematuria persists, then you can obviously either risk stratify the patient if they're microscopic hematuria, or if it's gross hematuria, then you can work that patient up. There is stratification using Triage Plus. You can get either a low risk, intermediate, or high risk. If it's a low risk, you can defer cystoscopy. An intermediate or high risk, you will be doing cystoscopy. Whether you do ultrasound or CT scan will be dependent on where the patient fits in the higher, intermediate, or high risk group. And of course, at the end, the cystoscopy is the most important thing. Thank you. If you need any more information for Cxbladder Triage Plus, including the availability in your country, please do contact us. I'm more than happy to answer any questions that you have. Thank you, and appreciate it.